Coming up in this episode, the next factor, which is an important one, is are the episodes clinically stereotyped? And what that means is if you compare 10 or 20 or 30 examples of the episodes, are they all the same or very, very similar? Are they carbon copies of each other? Hello, everyone, and welcome to the next installment of Risfeld Neurology Education, a not for profit, completely free, and easily accessible project exploring all areas of clinical neurology. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today's episode is going to be focusing on nocturnal hypermotor, also known as hyperkinetic seizures, and distinguishing them from physiological arousals from sleep and parasomnias. And this is an episode in the epilepsy and seizures series. This was actually supposed to be part of the previous episode on is it a seizure? Distinguishing seizures from seizure mimics. But that episode really dragged on, so I thought that I would split them into two episodes. So this is going to be a much shorter episode. There's actually only two main slides with content on them, but they're quite dense and there is quite a lot to talk about because this actually is quite a challenging topic. So I think let's dive into it. But before we do so, I will just say a legal disclaimer that the content involved in this project, so in this episode, in previous episodes, and in future episodes, is for educational purposes only. So, what type of patient are we talking about here? We're talking about someone who is asleep, and I mean truly asleep, not it looks like they're asleep and they're lying in bed with their eyes closed, but actually they're awake. And the reason that's an important distinction is you can't really, well, in fact, you can't at all have a psychogenic non-epileptiform spell, a functional episode, if you're actually asleep. But you can if you look like you're asleep, but you're not asleep. And we can distinguish that on an EEG helpfully. So if someone's got K complexes and sleep spindles and posts and vertex waves and slow wave sleep and REM sleep, then we can say that electrographically this person is definitely asleep. So the episode can't be functional. Conversely, if someone's lying still with their eyes closed, but we can see that they've got a nice well-formed alpha posterior dominant rhythm and no sleep transients, then we can say, look, this person isn't asleep. It looks like they are, but they're not. So an episode that appears to be arising from sleep isn't actually arising from sleep. So it might actually be psychogenic in nature. So we're talking about someone who is truly asleep and then they have these funny movements and maybe they wake the patient up, maybe they don't, maybe they wake the bed partner up, maybe they don't. And the question often arises, what is the cause of this? Is it a seizure? Is it sleep-related hypermotor epilepsy? Are they hyperkinetic hypermotor seizures? Or are they non-epileptiform in nature? Are they just physiological arousals from sleep? Or are they parasomnias, which is an umbrella term for a number of types of abnormal movements, which we'll talk about shortly? I have found these really quite challenging to distinguish between at times. And I think it's more challenging than distinguishing between some other seizure versus not seizure dilemmas in neurology, and it's a bit more difficult than determining the semiology of, say, a typical mesial temporal lobe seizure, for instance. But even though it can be difficult at times, it is achievable and there are ways to do it. So in this episode, I want to teach you all exactly how to do it. So, what are the mimics of seizures from sleep? So I mentioned physiologic arousals from sleep, and these are often exaggerated or confusional. So everyone rolls around a bit and does things in their sleep, which is completely physiological. I do it, and I'm sure that all of my listeners do it as well. And every video EEG admission that we do, when we're looking at the video and looking at the EEG, everyone, even when they're not having a seizure or they're not having an episode, they always roll around a bit or sit up or reposition themselves a bit or readjust the sheets a bit. It happens all the time, basically. But we're more talking about quite prominent physiologic arousals from sleep, or often very exaggerated or confusional arousals from sleep, where the patient may sit up and sit forward, throw the sheets off, look confused and panicked, sort of thing. So that would be an example of an exaggerated or confusional physiological arousal from sleep. And then there are these various parasomnias that I mentioned, and these are night terrors, REM sleep behavior disorder with the acting out of dreams, and sleepwalking, for example. There are some other parasomnias as well, but they're some of the main ones. Conversely, sleep-related hypermotor epilepsy-related seizures, which are characterized by hypermotor or hyperkinetic seizures, are of focal onset, but they then typically propagate bilaterally to cause hypermotor and hyperkinetic complex motor behaviours, which are classically asynchronous, bilateral, high amplitude, hip and knee flexions and extensions. So if you can imagine that, that makes a bicycling appearance, really. So if you have someone who has asynchronous flexion and extension of the right hip and the right knee, and then the left hip and the left knee, then they're bicycling. So it looks like they're bicycling in bed, or rolling over in bed, pulling off clothes, pulling off bed sheets, etc. So that's what a hyperkinetic or a hypermotor seizure can look like. And these can also incorrectly be labeled as psychogenic non-epileptiform spells because they can be really dramatic and they can look really odd and bizarre. And so it's very understandable how they can be mislabeled as being functional in their nature. And the other thing is, these seizures, even though they do mainly occur at nighttime, in some patients they can occasionally also occur when awake, but they shouldn't just be happening when the patient is awake. In terms of the part of the brain that they usually originate from, they usually originate from the frontal lobe. And so the associated epilepsy used to be called nocturnal frontal lobe epilepsy, but we now appreciate that occasionally they can be extra frontal in their nature. So they can arise from the temporal structures, for example. So that's why we don't call it nocturnal frontal lobe epilepsy anymore, and we call it sleep-related hypermotor epilepsy instead. One other point that I think is important to make here, that I did make briefly in another episode, but I'll say it again for the sake of repetition to aid memorization, is that there is a difference between a hypermotor hyperkinetic seizure and a bilateral tonic-clonic seizure. So although both forms of seizures involves positive observable motor activity affecting both sides of the body, which is excessive in nature, they mean very different things. So a bilateral tonic-clonic seizure is a seizure with a tonic phase followed by bilateral clonic, specifically clonic activity in the body, typically in the arms and the legs, in the whole body. Whereas a hypermotor or a hyperkinetic seizure is one of these seizures with these asynchronous, bizarre, complex, integrated, and often quite typical types of movements such as bicycling. So they are quite different phenomenologically, and a bilateral tonic-clonic seizure is classified as a bilateral tonic-clonic seizure, and ideally as focal to bilateral tonic-clonic or a generalized tonic-clonic seizure, depending on whether it's starting focally or everywhere, if you know that information. Whereas a hypermotor or hyperkinetic seizure is classified as a focal impaired consciousness seizure, even though it may well and usually would have to involve or propagate to both sides of the brain to be causing the bilateral motor activity. That doesn't make it automatically a bilateral tonic-clonic seizure, and that's something that I was really quite confused by and didn't understand for a long time, and it's actually only been this year that I've come to that realization. So I went through all of medical school, all of my junior doctor years, and all of my advanced training, and a few months as a neurologist before I actually learnt that. So it's a common misconception, and I know some epileptologists who also didn't realize this. So that's why I'm reiterating it to you all so that you can not fall into the same mistake that I fell into for so long. So, what are the factors that distinguish seizures, so hyperkinetic or hypermotor seizures, from parasomnias? There's a few. I've adapted this table from a conference lecture that was given at the Australian and New Zealand Association of Neurologists and Epilepsy Society of Australia's annual clinical epilepsy conference It's not copied. I've adapted it from some of that information and incorporated some other information, but it is heavily derived from that source. So, in regards to the factors and how they can be discriminating in terms of it being a seizure or a parasomnia, firstly, you've got to ask about and consider how often are they occurring each night. So, in sleep-related hypermotor epilepsy, you get lots of them, multiple, sometimes 5 to 10 or more. Whereas parasomnias, such as the REM sleep behaviour disorder or night terrors, they usually are less frequent, so maybe 1 or 2 per night. You've also got to think about when in sleep is the episode occurring. So, sleep-related hypermotor epilepsy seizures, so hyperkinetic or hypermotor seizures, they usually occur early in sleep. So, in the first 30 or so minutes of sleep in particular, so in stage 1, stage 2 sleep. Whereas parasomnias are divided into either non-rapid eye movement parasomnias or rapid eye movement parasomnias. And the majority of them are non-rapid eye movement parasomnias. And they typically occur in stage 3 or stage 4 sleep. And if you go back to your basic knowledge of sleep studies and of the phases of sleep and the way that they come on during sleep, we know that the deeper stages of sleep come on later in each sleep cycle, and the proportion of sleep, which is stage 3 or stage 4 sleep, can vary throughout the night as well. So typically parasomnias occur later in the night, whereas sleep-related hypermotor epilepsy seizures typically occur earlier in the night. You could identify that REM sleep behavior disorder is not an NREM parasomnia, that's a REM parasomnia. But of course, REM sleep is not present at the onset of sleep, apart from in the very rare circumstance of the patient having narcolepsy with sleep onset rapid eye movement periods or somREMs. But with the exception of a patient with narcolepsy, you're not going to have someone having REM sleep within the first 30 minutes of sleep. The next factor is the duration of each episode. So the seizures are usually briefer. So they're usually less than 1 minute and almost always less than 2 minutes in duration. So we're talking less than 1 or at most 2 minutes. Whereas parasomnias are typically longer. So they last for typically more than 2 minutes and sometimes more than 10 minutes. So there's quite a difference in the duration. The next factor is, do the events occur during wakefulness? So as I mentioned on the previous slide, sleep-related hypermotor epilepsy-related seizures usually occur overnight, but some patients sometimes also get seizures during the day, whereas parasomnias never occur when the patient is awake. You can't be awake in the middle of the day and have a night terror. That's a contradiction in terms. Or you can't be awake and be sleepwalking. So that's an easy distinguishing factor if there are episodes when the patient is awake. The next factor is, are the episodes triggered? So seizures usually are not triggered in this context, whereas parasomnias are sometimes triggered by an external trigger. Maybe there's a noise at the door or outside the room, or their bed partner accidentally kicks them in the leg. Or maybe there's an internal trigger, maybe the patient coughed, and that could be a trigger for the parasomnia. The next factor is, how discrete is the offset and what happens after the offset? Does the patient arouse to complete wakefulness after the episode? So in a seizure, the answers to both those questions is usually a yes. Not always, but it's often a yes. So usually a seizure happens and then it stops, and you can say where the time point is where it transitions from being on to being off. So it's got a discrete transition point from the state of being in a seizure to not being in a seizure. It's discrete. And then the patient usually totally wakes up after the seizure. They may go back to bed again very quickly, but they do wake up. Not always, but usually. And the inverse is true for parasomnias. So usually it's not a discrete offset. You can't clearly say when they're having the night terror or the sleepwalking or the REM sleep behaviour disorder or the other parasomnia. And when they're not doing that, it's more of a blurred line as to when the episode is actually finished. And often the patient may not, and usually, in fact, usually the patient does not completely wake up with these episodes. The next factor is, can the patient coherently recall the episode afterwards? Not the witness, not the bed partner, the patient. With seizures, sometimes they can, whereas with parasomnias, it's rare to be able to do so. The next factor, which is an important one, is, are the episodes clinically stereotyped? And what that means is, if you compare 10 or 20 or 30 examples of the episodes, are they all the same or very, very similar? Are they carbon copies of each other? And if the answer to that is yes, then that strongly favors seizures. And if the answer is no, then that favors parasomnias. So, for example, if someone always wakes up, and in this order, I should say, wakes up suddenly, sits up, gets their left hand, puts it on their left ear, uses their right hand to fling the bed sheets up, then starts cycling leg movements, beginning with the left leg, then yells, says the same word every time, and it lasts for the same length of time every time. And that exact same thing has just been repeated over and over again for 30 or 50 different episodes that you've seen or heard about, then that would be an example of a very, very highly stereotyped episode, and that strongly favors it being a seizure. In reality, they're not always quite so obviously stereotyped, and there can be small little individual variations in between episodes, but for the most part, the clinical features, including the order in which the clinical features come on and the side of the body in which the clinical features manifest, are fairly similar from one episode to the next, and that's what a stereotyped episode is. And whenever something is stereotyped, you've got to think seizures, you've got to think epilepsy. Some other things can be stereotyped, but you've really got to think about seizures and epilepsy, especially in this context. Conversely, parasomnias are usually not stereotyped in this way. So if someone's had night terrors, it might be a different nightmare or a different terror, and the observable motor phenomena might be a bit different each time. Maybe one time they'll roll to the left, the next time they'll roll to the right, the next time they'll sit up and throw the sheets off, and then one time they'll put their arms up in the air, another time they won't do that. So it's a bit different every time. And then the last group of features that can help distinguish a seizure from a parasomnia in this context is other helpful semiological features. So some helpful other features for seizures in terms of the actual semiology is dystonic posturing, head version, typical cycling leg movements, or cycling movements in the arms, I suppose, as well, rocking or thrashing movements, and hyperventilation and grunting noises. So they all favor seizures. Conversely, parasomnias, some factors that are helpful and suggestive of parasomnias are yawning, scratching, prominent nose rubbing, rolling over in bed, although this can be seen with seizures as well, interacting with another person in the room, or obvious sobbing or sad emotional behavior. So they all favor parasomnias. And it is worth saying that there are some non-discriminatory factors as well. So the following factors don't really help distinguish between a seizure and a parasomnia. And they are if both conditions come on in childhood, which they both usually do. And the other one would be they both usually feature an arousal prior to the onset of the other semiological features. So they both usually demonstrate the patient suddenly half waking up from sleep and then the other factors come on, as opposed to the other factors coming on and then the patient half waking up from sleep halfway through the episode or towards the end of the episode. Now, if in doubt, if you're not sure whether the episodes are seizures or parasomnias, the patient may well require inpatient video EEG, and that can give you the answer a lot of the time. But even then, you don't always get a definitive or a robust answer because you don't always get a robust ictal rhythm with sleep-related hypermotor epilepsy. And conversely, you can get some misleading rhythms with parasomnias, which have been termed these dissociative rhythms. And I have found it quite difficult to report video EEGs that I've reported when this has been the clinical question. And as I mentioned earlier, they can be more difficult than your standard mesial temporal lobe epilepsy. But a lot of the time it can be done and it is doable, but it's not a guarantee that you'll be able to distinguish them with EEG. Imaging is sometimes abnormal in sleep-related hypermotor epilepsy, and it's a bit of a giveaway. So, for instance, I had a recent patient like this who we weren't sure if it was sleep-related hypermotor epilepsy or confusional arousals or a parasomnia, but that patient had some imaging that demonstrated a frontal focal cortical dysplasia that anatomically correlated really quite nicely with some of the motor symptoms that that patient had. So that was a bit of a giveaway. Conversely, the imaging is usually normal in parasomnias, although there may be incidental findings that are not clinically relevant, and that would make it more difficult. So that's everything that I wanted to present to you today in regards to distinguishing sleep-related hypermotor epilepsy seizures, so hyperkinetic hypermotor seizures, from exaggerated physiological arousals or confusional arousals and parasomnias. I hope that some of you found this helpful because I think it's an important topic and a difficult topic, and one that I only recently got my head around, so I wanted to share it with you as well. So thank you for tuning in. Please like, comment, and subscribe. Visit our website, which is rneurologyeducation.org. That's R for the letter R, for all of our media formats and for additional content all in one place. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms. You can find us at R Neurology Education, with the exception of X, which is R Neuro Education. And email us on contact@rneurologyeducation.org for any questions or queries, or to subscribe for notifications when new content is released. From Cortex to Curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.